meetings. And this has been quite a surprise to me because I thought that we knew already that there is a major luteal deficiency in IVF very early in the game. As soon as we started IVF, we knew that there is luteal deficiency, and we thought that we found the solution by simply adding progesterone to our treatment. We all know that progesterone is needed for implantation and is needed for the pregnancy to continue. And we know that in the natural cycles, progesterone is secreted after ovulation. It peaks 7 to 8 days after ovulation, and then it drops if there is no pregnancy. Progesterone secreted by the corpus luteum, and the corpus luteum is under the effect of LH. So we cannot have a corpus luteum function well without having an LH activity. And we knew, this is a very old slide, we knew from the beginning that with IVF stimulation, the luteal phase is very short. Instead of being 14 days, it's almost 7 to 8 days. The progesterone peaks very high, very quickly, and then drops very quickly too. So these 14 days, slowly plateauing progesterone is completely disturbed in IVF. And now we know the pathophysiology for that. When we stimulate our IVF patients, we give high dosages of HMGs. This will increase the E2 for high levels. This is going to lead to pituitary downregulation of LH, and as we said, we need LH for the corpus luteum. So we have a insufficiency in the corpus luteum, low progesterone level, endometrial receptivity is affected, and low pregnancy rate. So we solved this by giving progesterone, as we said, early in our IVF treatment. And we have been spending the past 35 years in IVF mainly concentrating on stimulation protocols and technology to improve our pregnancy rate. We discussed a lot over the years which is the best stimulation, agonist or antagonist, which products to be used, urinary or recombinant. Technology, we spend a lot of money and a lot of research to improve our media, incubators, everything just to improve our pregnancy rate. The missing link all through has been the progesterone or the luteal phase, because as I said, we thought we did a good job by adding progesterone more than 20, 30 years ago. We did some studies related to luteal phase support in addition to progesterone, mainly the adjuvant, aspirin, steroids, estrogen, and they have all been shown through evidence-based medicine that they don't make a difference at all. So going back to the question, why now? Why now everybody's talking about the luteal phase support again? I think there are two reasons for that. The first one is the introduction of the GnRH agonist trigger, and the second one is the oral progestin, which is gaining momentum, especially this year. When we give GnRH agonist trigger, it has been recommended mainly for patients who are at the risk of hyperstimulation syndrome. So this is the gold standard for these patients. The question is, are we going to move into giving GnRH agonist trigger to all patients of IVF, regardless whether they are at the risk of hyperstimulation or not? And are we going to move into individualized luteal phase support, as we are going to see? And when it comes to oral progestins, if we are going to use these, does this mean the end of the vaginal supplementation that we have been using now for at least 30 years? Well, let's start with the trigger first. The SCG trigger traditionally has been used since day one of IVF. It is the gold standard in almost all of our cases. We know that SCG has similar activity like LH. It has a longer half-life, and that's why it is used also to maintain support of the luteal phase. The SCG trigger, when we use it, it is responsible for two things in our stimulation. It will induce the final maturation of the eggs, and it's going to maintain the luteal support for the first few days. So as you can see, when we give the SCG bolus, the LH activity, which the corpus luteum needs, is going to be supported for around 1 week, the time when we want to transfer our embryos. And at that time, we have a sudden decrease in the LH activity, and this is the time when progesterone is needed, and we start adding progesterone. But of course, all of us, we start progesterone treatment on the day of the pickup or the day after. So when we give the SCG is responsible for the egg maturation and early luteal phase support, and therefore these two events that are taking place in the stimulation cycle are linked together. They cannot be separated, the trigger and the luteal phase. GnRH trigger, agonist trigger, was introduced to prevent hyperstimulation syndrome in our risky patients. It has a completely different concept than SCG. The GnRH trigger will lead to endogenous increase in FSH and LH. So it is a natural LH that is being produced and the natural FSH. And this seems to be more physiologic. This is what happens in nature usually. And it has been shown that LH activity will help in the oocyte maturation as well. The problem with the GnRH agonist is that it does not have any stimulation on the luteal phase as we saw with the SCG. And this will lead to severe luteal phase deficiency. Because LH activity, because of the short half-life of the natural LH is very short, so the LH activity in the luteal phase is very limited to few days, 2 to 3 days maximum. And because of this very early luteolysis, we are going to end up with severe, as we said, severe luteal phase deficiency. So if you compare the two graphs, you can easily find how the SHG is backing up the luteal phase while GnRH agonist is not. So the GnRH agonist is responsible only for one event in the stimulation cycle. So if you compare it to HCG, which has two functions, the maturation and support of the luteal phase for a few days, when you give the agonist, we are going only to mature the eggs, and the luteal phase now is completely separated. It's standing alone in our stimulation. And the advantage of this, having now only the luteal phase completely naked in our hands, the advantage of this that now we have a complete control of the LH phase. So studies can be done to see the effect of estrogen, progesterone combination, so we can now manipulate the luteal phase the way we want. And this will lead to individualized luteal phase support. The disadvantage, as we said, is the severe luteal phase deficiency. And therefore, the standard luteal support that we use, the vaginal progesterone that we commonly use, is not enough in these patients. And this has been shown by very early studies in 2015 that have shown that there is a catastrophic decrease in the pregnancy rate when you give the GnRH agonist trigger and you use the standard luteal phase support progesterone only. 6% compared to 36% by two studies. And this was the base of the Cochrane review published 2014 that clearly mentioned that if you give GnRH agonist trigger, your live birth rate is going to be affected and is going to be quite low. And therefore, they concluded that there's a lower live birth rate, lower ongoing pregnancy rate, and a higher rate of miscarriage. And according to the Cochrane, we should not use the agonist except in patients in whom we are going to freeze all the eggs or we are using it for egg donation. Well, this Cochrane review was debated, criticized by many publications. And these publications, they simply say that the Cochrane missed the point completely. The problem is not in the GnRH agonist trigger itself. The problem is in the luteal phase. And these studies that were included in the Cochrane, they included studies with completely different type of luteal phase support. And that's why this Cochrane review should really be taken with a little bit of salt, grain salt. I don't know what to say. So, and they showed us also that the pregnancy rate, when you use LH supplementation, even in the Cochrane, when you use LH supplementation in these studies, you have an equal pregnancy rate, but if you don't use LH activity during the luteal support, you have a lower pregnancy rate. So this has led to more research, more talk about rescuing the corpus luteum whenever we want to give the GnRH agonist. And we have basically now two approaches, the European approach and the American approach. I'm going to quickly tell you how they are different and how to be used in your clinical practice. Well, the European approach, they depend on HCG activity to be given. So they give HCG in their treatment, simply to give some support to the luteal phase. It took some time to find what is the correct dose and when to be given. And now finally, this is the typical European approach. You give 1,500 units of HCG on the day of egg retrieval. And you continue with your standard progesterone treatment. You don't change your luteal support. And this is known as the Hmaidan also protocol. And Dr. Hmaidan is here among us in this meeting, and we're expecting him to talk probably a little more in the afternoon about this. So if you go back to the early studies that have shown only 6% pregnancy rate when you use standard LH, standard luteal phase support, mainly progesterone and estrogen, when you start giving the European approach, where you add 1,500 units of SCG on the day of pickup, your pregnancy rate is comparable to SCG. They're almost the same. There's no difference between them. But there remained a major problem. Although there's no difference in the live birth rate, but still there was a 7% less live birth rate in the GnRH agonist trigger. And when the data was scrutinized, it was found that this was due to the early pregnancy loss in patients who had lower than 14 follicles on stimulation. So patients who produce less than 14 follicles, these have a higher risk of losing the pregnancy early in pregnancy. And that's why this led to the concept of individualized luteal support treatment. It correlates mainly with the number of follicles that you obtain with your stimulation. And the individualized treatment, we have also 2 protocols now. 2 studies published, they have shown that if you produce eggs more than 14, you use the typical European standard protocol, which is the 1,500 SCG on the day of the pickup. If you have less eggs, less follicles, you give 2 dosages. Day of pickup, 1,500, and 4 days later, another 1,500 as a boost. And the other individualized treatment is that you can give on daily basis 125 units of SCG with no progesterone treatment even. And when they did that, you can see that it is for the first time that the pregnancy rate with the GnRH agonist is better than the SCG trigger itself. So to summarize, when you give the European approach, if you have less than 14 follicles obtained, you give the 2 dosages of SCG with the standard progesterone treatment. If the patient gives you 14 to 25 follicles, these are a risk of hyperstimulation, you give only 1 dose. The day of the pickup, more than 25 oocyte, we don't have yet data, but freeze all seems to be a good option. And when a meta-analysis only just recently published related to the only European approach studies, 5 were included, although the quality of these studies were a little bit low, but they have shown that the live birth rate is not different between trigger, GnRH agonist trigger, and SCG, but the trend was for a better pregnancy rate with SCG yet. But when they analyzed the recent study with individualized treatment that I have shown you before, they are exactly the same pregnancy rate. The early pregnancy loss was still more common in the GnRH agonist trigger, and this is probably because most of the studies included in this meta-analysis, they stopped luteal phase support when the test is positive. Only 1 study continued to 7 weeks. So probably when we use GnRH agonists, we need to push our support with progesterone probably till 12 weeks. The American approach completely ignores the corpus luteum. It doesn't exist for them. Instead, they give huge doses of progesterone and estrogen. The recommended doses is to give 50 milligram IM progesterone on daily basis and to give estrogen 0.1 milligram transdermal patches every other day. And this was based on a study back in 2008 by Engman that have shown that patients who are at the risk of hyperstimulation syndrome, producing more than 20 eggs, these patients, if you give them the American approach, high dosages of progesterone and estrogen, the pregnancy rate is similar to SCG and the hyperstimulation syndrome is almost disappeared. The problem with the American approach is that you have to monitor your luteal phase. So they suggest measuring estrogen and progesterone every week, and you need the estrogen to be more than 200 picogram, the progesterone more than 20 nanogram, and accordingly you adjust your dose by increases the dosages if needed. There's still debatable which is the best way to give progesterone. Is it IM? Is it vaginal? Is it a combination? What are the dosages and the pain related to IM injections? The route of estrogen is still debatable. Is it patch? Is it oral? And the problem, as I said, with the monitoring. And that's why if you want to give these, according to the recommendation of the American approach, if you want to give this treatment up to 10 weeks, you can imagine the patient taking on daily basis IM injections and all the discomfort of this. And that's why probably the European approach is the ideal to be used in these patients. Just 1 minute about other modified corpus luteum support. We have the recombinant LH, 300 units every other day, as shown to give adequate pregnancy rate. Dual stimulation, giving GnRH agonist plus HCG at the same time, range between 1,000 to 6,500, also similar pregnancy rate. And a very interesting paper where you give 1,500 on the day of pickup, 4 days later, another dose of 1,500 HCG, no progesterone at all, very good pregnancy rate. So probably we are going to see more and more of these protocols supporting the luteum. So if we agree that the GnRH agonist is used mainly to prevent hyperstimulation in high-risk patients, and now we have data to support that the pregnancy rate or its outcome, the reproductive outcome, is as good as the traditional progesterone supplementation, shall we shift all to the GnRH agonist trigger in all IVF patients? Especially it is more of a natural way of inducing ovulation and maturation of the egg. I think, yes, probably we are going to move into this era very soon. And this will lead to a new ideas about supporting patients when we use GnRH agonists. The second one is the oral progestin. Are we going to witness the end of the vaginal progesterone supplementation? We all know that vaginal progesterone is used in most IVF centers. And we know that it is effective, but at the same time, we know that it has some problems, irritation, discharge, and so on. Oral progesterone, the micronized oral progesterone, is not effective. It will lead to low bioavailability with major side effects. The IM progesterone, we all know its side effects, pain, and possible infections. The dydrogesterone is a synthetic progesterone that has a greater affinity to progesterone receptors compared to the progesterone itself, and doesn't have affinity to androgenic, glucocorticoids, and other receptors. And probably there is an element of safety when we use dydrogesterone. Cochrane review, 2015. They studied this molecule based on the 2 available studies then that reported live births, and they have shown that dydrogesterone compared to the vaginal progesterone, they are equally effective. But the evidence there was considered to be low. In 2016, another meta-analysis was done. This time they included more studies, and now they have shown that the clinical pregnancy rate is better with the dydrogesterone. The ongoing pregnancy rate was not different, but the trend was in favor of dydrogesterone, and the treatment satisfaction was much better with the oral one. Despite all of this, the meta-analysis, the Cochrane, and so on, introducing the dydrogesterone in the practice in IVF clinics has been very limited. And the reason for that is many centers, they believe that these studies that I have shown you, some of them are coming from same center, some of them coming from India, some of them coming with very low, good evidence, and that's why nobody really was interested in using dydrogesterone until last May 2017, when the Lotus 1 study was published. And this is considered, by all means, one of the best studies done on luteal support ever, because the way they conducted the study was not done before on any molecule, as I said, in progesterone treatment. In this study, it was double-blind, double-dummy, multi-center studies in Europe, okay? So what they did is that when they did the pickup, they divided the patients into 2 groups. One group received the dydrogesterone 10 milligram TID plus vaginal placebo. The other group received the vaginal progesterone 200 milligram TID plus oral placebo, okay? They were given for 2 weeks. Test was done. If it is positive, the treatment was continued for 12 weeks. And the primary outcome objective of this study was to see if the dydrogesterone was inferior to the vaginal progesterone. And this was assessed by a positive fetal heart at 12 weeks. Other secondary effects, live birth rates, positive pregnancy test, and newborn assessment were also done. I'm not going to talk about the sample size because of the time, but they needed around 500, more than 500 patients in each arm so that they reach a good statistical power. And they have defined non-inferiority, so they will consider the dihydrogesterone to be non-inferior, not less than the vaginal progesterone, if the lower arm of the confidence interval does not cross the -10. And this is a standard that they use in many publications. So this is a standard way to assess non-inferiority. So if the lower bar of the confidence interval crosses the -10, the product will be considered as inferior to the vaginal one. There was no difference in demographic between the two groups. The results. The main objective, 12 weeks positive fetal heart, there was no difference between dihydrogesterone and the vaginal progesterone. And therefore, it was considered to be non-inferior because, as you can see, the lower limit of the confidence interval did not cross the -10, according to the definition. The live birth rate also was the same. But surprisingly, now we have almost 5% better pregnancy rate with the dihydrogesterone. Although this is not significant, but when we start talking about live birth rates, every single percentage is important for us. And when you dissect the data a little bit more, you see when the test is positive, 2 weeks after supplementation, they are equally effective, the vaginal and the dihydrogesterone. But as you go further in the pregnancy, especially during the first trimester, you are going to see that there is a shift into a higher pregnancy rate, not significantly different, in favor of dihydrogesterone, reaching up to 5%. So does dihydrogesterone actually decrease the risk or the incidence of early miscarriage? I think we have to wait for more data. Maternal adverse effect, no difference between the two products. Fetal adverse effect, also there is no difference. Many parameters were studied. Newborn outcomes, the weight, Apgar score were the same. So the conclusion of this is that it is the first time we have a real robust evidence that dihydrogesterone is as effective as the traditional standard vaginal progesterone that we use. And it is quite safe. The data supports its safety very well. So the question that is raised now, if we add the data from the Lotus 1 study to the data of these small studies that I have shown you before, and the meta-analysis is done, are we going to have a conclusion saying that if you give dihydrogesterone in IVF supplementation, you're going to have a better pregnancy rate? I think we have to wait till they have such a meta-analysis done. We all know that our patients prefer oral progestin. This is for sure. And it seems from the recent evidence produced by the Lotus study that yes, we might have a change in the paradigm of giving luteal support in IVF. So are we going to witness the end of vaginal progesterone supplementation in the coming few years? Thank you very much.